see how young budding physicians are thinking and what the cutting edge sort of topics and nuances are out there. Because as you move forward, you kind of lose touch with what is the most cutting edge stuff, and you kind of get lost in your own sort of area of expertise. So it's just so refreshing. I love the energy. I love the energy of the folks that are here to present for us today. So without further ado, just a couple of things. Number one, of course, IAMA events that are coming up. We have a walkathon coming up, so if you're interested, please register and join us. That's going to be the first weekend of October. We have yoga class this Sunday. If you're interested, just check the website and you can join. That is free of charge, of course. Importantly, we have the gala on December 7th at the Matrix Club in Naperville, so please, please join us for that. That's going to be a lot of fun. The other thing I want to mention about today's event is Tapan Parikh. Dr. Tapan Parikh, where are you? I just want to say a special thank you to Dr. Tapan Parikh because there he is. Big round of applause. So Dr. Parikh has kind of been our in-house, like, executive academic chair for years now. I mean, he's been working on either supporting, leading, or taking over for this event for at least 3 years now, and IAMA appreciates his support and his work very, very much. And then I also want to introduce one of our academic co-chairs for this year, Dr. Janathan Maidam. Please stand up. Will the real Janathan Maidam please stand up? There he is. So, Dr. Maidam works in pediatrics. He works at Cook County, in the Cook County healthcare system, and also in many other hospitals. So, for those of you upcoming physicians over there, I want you to, if you have any interest in pediatrics, pick his brain for sure. He's an amazing academician and teacher, and he also is the clerkship coordinator for Windsor University School of Medicine. Did I get your title right? I hope so. Something along those lines. He's the lead director for that area, pediatrics clerkship in Windsor School of Medicine. So he does a lot of teaching, and he's a worthwhile person to speak with, as are many other people in the audience whom you will come to know as you chat as the evening progresses. So, without further ado, let's start. So, this is, I've already explained to you all, but what we'll do is I'll call you up here. I want you to go ahead and do your presentation. I'm going to give you a 1 minute kind of indication, okay? So, you have 5 minutes to present. I'll let you know we now have 1 minute left, and then we have a few minutes for questions and queries from the judges, all right? So the first presenter today is Megan Munian. She's an M3 at Ross University. Please welcome Megan.
All right, hi everyone. As previously mentioned, I'm Siddharth. This is Megan, and this is our presentation on establishing the correlation between eye tracking patterns and self-reported moral injury in veterans diagnosed with PTSD. Next, please. So starting off with the purpose of our studies here is to gain a deeper understanding of moral injury and moral distress. We want to use eye tracking, a technology that assesses several measures of eye movements, and along with self-reported measures of moral injury. We want to analyze self-reported measures, questionnaires, and eye tracking data to gain valuable insights into identifying and detailing moral injury and moral distress, as research in this field is still very much in its nascent stages. Overall, we want to contribute to a better understanding of the relationship between an individual's subjective experiences and observable eye movements, ultimately expanding the body of research on MI and eye tracking. Next, please. So now for a bit of background, diving into what exactly moral injury is. Moral injury stems from the perceived transgressions of one's own values and beliefs. This usually culminates in feelings of betrayal, self-condemnation, and even shame. The reason that research in this field is so important is it's very much associated with post-traumatic stress disorder, anxiety, and depression. The specific population we've chosen to study is veterans, mainly because oftentimes in veterans, due to their combat experience, this can lead to those transgressions of one's own morals. And then jumping off that to what exactly eye tracking is, eye tracking involves the observation of patterns in eye movements and as well as the duration of these behaviors. It's been widely used in psychological research to gain an understanding of reactions to emotional stimuli, motivation, perception, and attention. Several studies have been done in the past which correlate eye tracking behaviors such as hypervigilance to negative stimuli to PTSD. Now we seek to break ground on research examining eye behaviors more specific to patients with moral injury. Next, please. Now, starting with the methods, going into participant and recruitment. Our participants will be veterans who are diagnosed with PTSD and who have experienced MI and MD as reported on self-questionnaires. They'll be recruited in collaboration with the Department of Mental Health and the chaplaincy at level FHCC. They'll include, the recruitment methods will include staff referrals, flyer distributions, phone call, and word of mouth. And we aim to get about an estimated 20 participants. Inclusion for the study include participants who are veterans who have experienced MI, who have a history of receiving treatment, and possess normal to or corrected to normal vision. Exclusion criteria will include eye impairments such as cataracts, glaucoma, and color blindness, as well as conditions such as dementia and recent substance abuse.
All right, so to continue with the methods, we're going to have a three-pronged approach. So first we have self-reported methods. One of them is the combat exposure scale, and that was first made during the Vietnam War to measure the extent of combat exposure in military personnel, so the frequency and intensity of the combat, the type of experience, and the psychological impact. We also have the moral injury and distress scale, and this features more on the moral conflict, so the feelings of guilt, shame, and betrayal related to actions that they find that's against their moral beliefs. We also have the distress unit of distress scale, and so those are the three questionnaires. Then we also have a questionnaire that collects the participants' perception of moral injury and distress, so like their own moral injury and how they prefer to be treated. And then lastly is the eye tracking technology, and will be utilized to monitor the participants' eye movements while they're viewing moral injury stimuli. So this is pictures or words or sounds. And the eye movements include gaze position, dwell time, attention bias, and pupil dilation. And all of this will be examined in the eye tracking software. Next, please. So this is kind of what the setup would look like. We have one of these in the James A. Lovell facility. It's an enclosed space. There's no windows. There's no other distractions. So it's only just the participant and the researcher. And it'll just be recording as the participant views the moral stimuli. Okay, next, please. Implications, so there's very few risks in this. There's no physical risks, and if the participant does have any emotional distress from viewing the stimuli, then we will have health resources available for them. And then this study is important because it'll contribute to research aimed at improving veteran care, advancing science, and detection and interventions for individuals with moral injury and moral distress. These are our references. And then this is our team, Dr. we want to thank Dr. Baird, Dr. Zacconi, Dr. Swaminathan, James A. Lovell, and the rest of our students. Yeah, and any questions? Well, I'm interested in psychiatry, so I've just been trying to learn more about psychiatry research. And I've worked with Dr. Baird with other projects before, so he invited me into this one. Yeah.
So,
Yeah.
do you want to go?
Oh, no, go ahead.
Yeah. So right now this project is in its beginning stages. We just wanted to report on what we're going to be doing. When we do have the conclusions, hopefully next year at the Golden Stethoscope Awards, we'll be back with more data.
This is Siddharth Suresh. He's an M3 at Rosalind Franklin, so thank you again for being with us. Did somebody have a question? All right, wonderful. The next presenter is Angela Hussein. Angela Hussein is an M3 at UIC. Please welcome Angela.
Okay, hi everybody. My name's Angela, and I'm presenting on the ACL and its response to changes in the medial meniscus. So, as an overview, the ACL is an important ligament in the knee joint that functions to maintain joint stability and also helps with the knee mechanics. Oh, could we change the slide? And it also helps with knee mechanics. It also works with other structures to help distribute the forces evenly. And notably, it helps distribute the stress on other forces such as the meniscus. And so a lot of research is done that really looks at like the ACL and changes to the ACL and how that affects knee joint stability. But our research takes a novel approach where we look at changes to the medial meniscus and how that in turn affects the stress on the ACL and how the ACL compensates for such changes. And then specifically in this, we're looking at changes such as horizontal cleavage tears, which I'll refer to as HCTs, partial meniscectomies, and then partial transplantation as well. Next, please. So our hypothesis was that the horizontal cleavage tears will increase the contact pressure and decrease joint stability, thereby inducing compensatory stress on the ACL. Conversely, we anticipated that partial transplantation, which is used as a method to repair the meniscus with such injuries, would preserve the joint mechanics closer to the intact condition, therefore resulting in less stress on the ACL. So in this experiment, we took 7 freshly frozen human cadaveric knees, and we had 4 different testing scenarios. They were the intact knees used as the control, knees with a partial HCT, and then knees with a partial meniscectomy, which is where part of the meniscus was removed, and then knees with partial transplantation, which was the repaired. And then, so we also, with this model, applied an axial load to stimulate the forces that would be done with standing. And then this was also done at 0 degrees to mimic complete extension at the knee joint, as well as 30 degrees to mimic some degree of flexion. Next. So this is a bar graph that shows some of the results from the study. And the first box is the results shown at 0 degrees. And of note, for the results, this is also on the meniscus, the contact pressures. At 0 degrees, there was a statistically significant increase in contact pressure for both the HCT conditions and the meniscectomy conditions, as well as a significantly significant decrease in contact pressure with the transplantation compared to that of the HCT. And these results were also conveyed at 30 degrees flexion, but notably the increase for HCT was not statistically significant, but the trends were still the same. And the contact pressure pattern transitioned notably from the posterior lateral surface of the meniscus to an anterior lateral aspect with the HCT and the meniscectomy conditions. So in the next slide, this is our finite element analysis model that we used, and we designed it and verified it with using sensors in the meniscus to go over the different contact pressures and how those changed with the different conditions. And through validating this model, we then applied it to simulate what the stress would be on the ACL in the different testing conditions. And of note, at 0 degrees and 30 degrees flexion, our analysis revealed significant variations in the stress on the ACL, among the different testing conditions, with an increase in stress for the HCT and meniscectomy conditions, and a significantly significant decrease with the transplantation compared to that of the impaired. For the next slide, this is just kind of an overview of some of the numbers at the different forces applied at both 0 and 30 degrees. Next. And then, so in conclusion for this study, we concluded that the experimental and computational results validated stress patterns on the ACL and that are associated with meniscus injuries, explicitly addressing HCTs and subsequent repair methods. The HCT and partial meniscectomy significantly increased stress on the ACL and decreased contact area compared to the intact conditions. The transplantation with an autograft reduced the contact pressures following meniscectomy and HCT, and the stress and contact area variations were observed with different degrees of flexion. And the FAA model appropriately demonstrates similar patterns to the experimental results. However, variations may occur depending on the material properties used in the modeling details. And that is all. Thank you. Yeah, so not currently. So the goal of this study was to kind of get an idea of what repair methods that we would want to use and like have more indication to use in the future that would lead to more natural response in the meniscus after repair. And so through this research, we kind of validated that using like an allograft or an autograft for a meniscus repair does create conditions in the meniscus that is very similar to its like native natural conditions. So we want to take this research and then apply it to clinical models in the future to then like further validate the use in like humans.
Next, I'm going to, thank you. We have a clicker. Wonderful. For the next presentation, I'd like to invite back to the podium Siddharth Suresh, as I mentioned earlier, because I didn't introduce him before. He's an M3. Rosalind Franklin, please come back and share your research with us, please.
Hello, everyone. Nice to see you again. Okay. Oh, the clicker. Perfect. Thank you. So I'm Siddharth, currently an M3 at Chicago Medical School at Rosalind Franklin University, and this is my project assessing the utility of diagnostic ultrasound over MRI in the imaging of peripheral nerves. I took a case study, essentially. Diagnostic ultrasound is emerging as an incredibly invaluable and widespread tool in the imaging of peripheral nerves. In 2024, ultrasound studies accounted for about 33.9% of all imaging studies performed by radiologists in the US, according to Medicare data. Advances in high-resolution imaging transducers and superior imaging reconstruction have greatly improved imaging of peripheral nerves. They're especially useful in detecting post-surgical changes in these nerves, including complete or partial lacerations, epineural hematoma, and neuroma formation. However, there is limited efficacy in the discernment of neural wraps, limited information on the efficacy of ultrasound in discerning neural wraps. So now going to the background of what exactly these neural wraps are. Neural wraps are designed for the protection and support of nerves, especially after surgery. They're used when there's a minimal gap between injured nerves and used to bridge them together. They prevent adhesions, reduce scarring, and optimize the environment for proper healing. And as you can see over to the right, include a small diagram of that wrap. So now moving on to the case presentation. In 2019, a 66-year-old woman with a past medical history significant for hypertension presented to orthopedic oncology at UCSF for evaluation of a palpable soft tissue mass in her upper arm. Fine needle aspiration indicated an undifferentiated pleomorphic sarcoma, and the mass was excised. In 2021, a surveillance MRI showed a recurrent enhancing mass in the triceps region. The tumor was encasing the ulnar nerve, so partial nerve resection was performed with the follow-up residual tumor resection. Now moving forward to 2022, there was an additional occurrence with wide excision and neuroplasty of the median and ulnar nerves. There was a referral to neurosurgery due to extensive involvement of the ulnar nerve, and fifth excision with additional resection of the nerve and placement of a nerve graft was done. This nerve graft was harvested from the sural nerve. An MRI performed 3 months post-op was done, and this was followed by a sequential ultrasound to confirm and clarify the findings. And now I'll get into the imaging findings. Over here we can see the first MRI. On the left in image A, we can see a fat-saturated post-gadolinium contrast image, which shows an enhancing mass, as you can see with the arrows, at the site of the prior surgical scar, which was concerning for recurrence. Post-surgery, we can see in image B, there was still an enhancing mass at the site of prior recurrence, and given the history of multiple prior occurrences, this was concerning for residual or recurrent pleomorphic sarcoma. The enhancement is somewhat difficult to note on the screen right now. It is important to note that the MRI was limited by the large field of view that was obtained to cover her entire surgical site, and given the questionable findings on MRI, a diagnostic ultrasound was recommended prior to biopsy or surgery. And as you can see here, these are the initial ultrasound findings. Diagnostic ultrasound of the concerning finding on MRI showed a round abnormality with a well-defined hyperechoic rim and internal heterogeneous echogenicity. Upon comparison with the operative note and further sonographic evaluation, the center of the structure correlated with the sural nerve transfer. We can see that through the long arrows with the tails, and the external echogenic ring correlated with the nerve wrap, which is you can see by the thicker nerves, the thicker arrowheads. And over here, I've included some transverse ultrasound images, and they once again demonstrate both the sural nerve graft as well as its neural wrap. The area of concerning abnormality on MRI correlated with the distal wrap. So now moving on to the discussion. Overall, this case demonstrated the utility of ultrasound evaluation of post-operative changes of the nerve. Initially, the MRI was somewhat concerning for recurrence of the pleomorphic sarcoma, but upon further evaluation with the diagnostic ultrasound, we were able to see that rather than recurrence, this was actually rather an artifact from the neural wrap. Ultrasound offers a high spatial resolution and specifically offers adaptability for patient-specific exams. In the literature, I was able to find that animal studies done have shown an accuracy of ultrasound in mapping morphological changes in conduit placement. However, there is a dearth in literature of human studies required to gauge practicality and efficacy of ultrasound. Furthermore, ultrasound is a viable alternative to MRI in neuroimaging. MRI, as previously stated, can sometimes be limited by poor spatial resolution of artifacts, in this case, the neural graft. And ultrasound is readily available for point-of-care contact, and in terms of practicality, it is more affordable and portable. So much more inclined for point-of-care contact with patients. So now moving on to the implications and wrapping up, practitioners unfamiliar with the expected appearance of nerve grafts, wraps, and conduits sometimes may mistake the ultrasound appearance for other abnormalities. Therefore, familiarity with the normal appearance of nerve wraps and conduits is very important to accurately describe these post-operative findings. From an education perspective, which is why we pursued this project in the first place, ultrasound performance and interpretation should be further incorporated into the training of both young doctors and students due to its prevalence and benefits. And here we're excited. And then thank you, and special thank you to Dr. Reena Patel and Jonathan Friedman at UCSF for allowing me to work with them on this and letting me write up this case. Any questions? Yes, right now the gold standard of imaging is MRI. However, in this specific case, one thing that kind of drove me to report on this case was in this situation, MRI necessarily wasn't the most optimal because it, again, wasn't able to differentiate between the recurrence versus the artifact of the wrap. I do think further studies are necessary in order to demonstrate how MRIs can image properly neural conduits, neural wraps, as well as versus ultrasounds. This was more of a case presentation, so it was just one patient, yes. I believe this, when I was doing my literature background review, I wasn't able to find any specific past case reports of patients with these findings, especially in regards to using ultrasound after MRI to evaluate for recurrence, and that's why, again, partially I wanted to write this up. I'm sure maybe in the future this would make a great research point.
Oh, thank you. All righty. Yeah. Okay, so my name is Cadence, and I'm an M3 at UIC, and today I'll be discussing computational engineering of spinal wedge fracture validated by experimental compression in porcine and human vertebrae, and this work was done in Dr. Amarush's lab at UIC. No financial disclosures. So a little bit of background on vertebral compression fractures. They occur in 1 to 1.5 million people in the US each year, the majority of which involve the thoracolumbar region, which we're studying. And we're specifically interested in the wedge fracture, which is demonstrated on the right-hand side. That involves an anterior collapse of the vertebral body in comparison to the rest of the vertebral body. Risk factors for this include increased age, osteoporosis, high functional demand, and it leads to increased morbidity, mortality, and usually requires surgical correction. So for the purposes of this study, we have 3 main goals. The first is to validate a computerized mathematical model of vertebral compression fractures using finite element analysis. We'll explain what that is later. The second is to validate that mathematical model with physical experimental compressions. And the third is to compare the behavior of human and porcine vertebrae in their behavior to assess the porcine model as an analogous model for preclinical study of the spine. So to target our first goal here, we needed to first make a mathematical model for our vertebral compression fractures. So that's done using finite element analysis, and what that is essentially computer engineering to see how any kind of material responds to any kind of force or load. So for our purposes, that's the spine. We took 16 cadaveric human vertebrae and 12 cadaveric porcine vertebrae. We had them undergo CT imaging, and from that CT imaging, we were able to reconstruct a 3D model of these vertebrae. And this is just an example of that dissection process. And from there, once we have our 3D models, we can assign them material values like the density, and then assign a force to them. So that's what we did. So we performed axial compression on our vertebral bodies. Again, because we're trying to look at that vertebral compression fracture, the axial load to create this wedge fracture. So this is just an example of what that looks like. We can see the PEEQ, that's the plastic strain equivalent. And this is just, again, an example of early on in the compression and then later in the compression, we can see how the vertebra is actually responding to that axial load. And the software collects data on the load to failure, the stiffness, the strength, etc. And so next step 2 of this project, is to validate this experimentally. So we took those physical spines that we had and we originally CT imaged, and this is just the setup for our compression experiments. We wanted to make sure we were getting an appropriate force at the right area. But what we did is we did the physical experimental compression on these. So we have our mathematical model, now we're doing the actual vertebral compression. And this is the data that we found. We also tracked the stiffness, the peak load, the load versus extension. And in that bottom left-hand side, you can see, once again, before and after of that axial compression. And I'll show them side by side in a bit, but this is just to visualize the fracture pattern that we're seeing in the experimental experiments. And so now, the million-dollar question is, how did they line up? Mathematical versus experimental. And so what we're seeing is that on the left-hand side of the screen, in that black line, that's the experimental compression. Those red dots are the mathematical compressions. And we see a really nice linear and correlated pattern between our experimental compressions and our mathematical compressions. On the right-hand side of the screen, we have a line of best fit with our experimental compressions on the y-axis and our finite element analysis on the x-axis. And we see a really nice correlation there as well. So our mathematical model is successful in depicting and simulating what the actual physical vertebra is doing. So we have an R-squared value of 0.71 for our stiffness and 0.89 for our peak load, so that's quite impressive. So in conclusion, this is that side-by-side I was mentioning before. In conclusion, our mathematical FEA model was accurate in predicting the actual physical vertebral response to load. And this is, you can see on the right-hand side, not only is it accurate in the areas that it was predicting the failure, but it was also accurate in the previous slide, like I mentioned, peak load, stiffness, strength, all that. And so very successful. What I didn't have as much time to focus on was the comparison between the human and the porcine samples. Even though I didn't have as much time to focus on that, we did see a correlation there as well. And that's very important for being able to support that porcines are an analogous preclinical model to be used in research. And that's important because they're more financially accessible, generally accessible. And so future directions with this study is we want to evaluate not just the vertebral body, but the whole spine process in vertebral compression factors. We want to look at the risk factors I mentioned, like osteoporosis, the risk factors in population differences. So that'll be next steps. And with that, I would like to thank everyone in my lab, and I'll take questions at this time. Yes, so that is a great question, and that's part of the reason why we included porcine spines in this study is because we're currently cadaveric spines and vertebrae for a wide variety of diverse patient populations are not available. It's pretty limited what you can get in terms of osteoporosis, in terms of different patient populations. So part of the reason we're looking at porcine here is we're saying, well, we have porcine models for all those different things, obviously not racial demographics and whatnot, but for osteoporosis and other physiologic conditions. And so what we're saying is that right here, we've proven that the vertebrae do behave analogously to humans. So therefore, it may be a more accessible model to study some of these other conditions that we're discussing. But obviously, we would love to use human samples when available and when appropriate. Thank you. Thank you.
Thank you, Cadence. The next presentation, for the next one, I'd like to invite Deanna Bradley. Deanna Bradley is an M3 at the University of Illinois at Chicago. Please welcome Deanna.
Testing. Can everyone hear me? Awesome. Okay. So hello, my name is Deanna Bradley, and today I'll be talking about lip changes in patients with dentofacial deformities after Lefort 1 maxillary osteotomy. So I have no disclosures. So as an overview, the Lefort 1 osteotomy is a procedure that involves an intentional fracture of the maxilla in order to correct mid-face deformities as well as address issues such as underbite, and can lead to increased satisfaction in terms of appearance as well as functional utilization. And so why looking at soft tissue change and upper lip change in particular is important is because upper lip change can impact incisor show, and we have seen that incisor show is an important aesthetic parameter, which is why we thought this would be an interesting and important thing to study. And there have been studies that show that the Lefort 1 does impact soft tissue. What has not been studied is exactly how much it impacts study and how much the vertical and horizontal advancement impacts that soft tissue change. So our research question is, how much does the horizontal and vertical maxillary advancement during Lefort 1 osteotomy impact lip morphology in both cleft and non-cleft patients? So our patient demographics are that we had patients who had gotten the Lefort 1 osteotomy or setback surgery after the age of 16 due to just growth factors and change after the age of 16 being minimal, no history of orthognathic surgery, no congenital abnormalities other than orofacial clefting and facial asymmetry, no syndromic diagnoses, and they had to have a complete set of CT and 3D images. So part of our methods is that we use CT scans preoperatively, 1 month postoperatively, and 6 months postoperatively. And so we then took those CT scans and created 3D renderings using mimics and did landmarks, and then we did statistical analysis stratified by patient populations. So here's an example of some of the landmarks and measurements that we made and utilized, and here's also some of the 3D renderings. We had 15 hard tissue, so kind of just like on the actual bone, and then 12 soft tissue. And then we also had 4 planes that we used to kind of isolate vertical or horizontal movement. And then some of the measurements that we looked at was A point, which our A point is kind of what we use to measure our horizontal or vertical movement, as well as lip height, lip thickness, lip width, nasolabial angle, incisor show, as well as occlusal show. So here's some of our results. So just looking at broadly maxillary movement, we did see that we had larger in general movement in cleft patients than without cleft patients, and we also have some averages in terms of relapse, and so relapse would just mean how much after the surgery they would go back to their original, I guess, position. And so we did have a little bit of relapse, about 1 millimeter, but overall we just saw more maxillary movement in cleft patients. Moving on. And then so this is looking at our lip height. And so we did find that lip height was positively correlated with vertical lengthening. And so that's how much the maxilla was moved down. And so we saw that increased amount of vertical lengthening also led to increased lip height. And that was statistically significant. And then looking at nasolabial depth, we found that nasolabial depth in patients without cleft was positively correlated with change in both horizontal and vertical advancement. So that's moving forward as well as down. And then one thing that we also wanted to look at was how our findings differed between cleft and non-cleft patients. And so we did see that there were significant differences in nasolabial depth between populations at 6 months, with cleft patients having an increased change as well as decreased depth. And so to clarify what nasolabial depth is, that's looking at the angle between like your nose and your lip, and so that's also another aesthetic parameter that we're looking at. And so seeing that there's significant differences with cleft patients is something, between patients is something that's important because, sorry, let me move a little bit. It's important because it allows for increased planning in terms of cleft patients and understanding that they will have different changes. And then so this is just looking at our difference between time points. And so we saw that both lip height and occlusal rotation was different between pre-op and 1 month and 6 month values, just showing that although we didn't see a correlation between vertical and horizontal change in relation to these these parameters, we do know that they're different after the surgery. For the sake of time, I'll skip this, but this is just our model kind of looking at incisal show, just showing a lot of variability in that respect. And here are some of our other studies, just kind of looking at some of the less significant things. And so to conclude with our future work, we are seeing that, in patients with cleft lip and palate who have undergone the Lefort-1 osteotomy, increased vertical lengthening, significantly increased lip height, and show significant differences in vertical movement and nasolabial depth. And we're also seeing that cleft and non-cleft patients have different soft tissue outcomes based on the horizontal and vertical advancement. And so our future work is going to focus on increasing our patient population. Currently, we had 59 patients, with 31 being cleft and 28 being non-cleft patients. And then we're also going to do additional 3D analysis, looking to make a 3D mesh in order to better analyze some of our change and develop a predictive formula in order to predict for surgery outcomes, how we can measure the soft tissue change. And that's it. Thank you. Questions? Yeah, that's a really great question. We actually did not stratify our patients by race or gender, but I do wish that we had maybe done some of that. We had a hard time just getting a full population study in general, but I would say the general racial demographic of the patients that we see in the clinic are majority Caucasian patients, and I would say that we might skew a little bit more on the male side of things, but I think that's a really great point and thing to think about as well. Mm-hmm. Yes. Yes. So it was 59 in total, and 31 of them were cleft, and then 28 were not. And even within our cleft patients, we did have some who were unilateral, right, left, and we kind of just adjusted in our 3D modeling to make sure that they were, if it was right, we flipped it so that it'd be left to ensure consistency when we're looking at our cleft population. Oh, I don't have it off the top of my head, but the oldest that we had was 18 for the most part. So it was like kind of that 16 to 18 range. And granted too, some of these time points, right, we're looking at, before operation, so patients might come into the clinic maybe when they're like 12, 14, and they kind of like age up, and then you have the operation, and then, so we have some of these patients, we have studied their scans from 3 years later, but for the sake of having a robust like sample size, we tried to focus just on the 6 months for now. Yeah. Thanks.
Thank you, Deanna. All right. Our next presentation is going to be from Akash Gandhi. Akash Gandhi is an M3 at Windsor School of Medicine, Windsor University School of Medicine. Thank you so much. You're welcome.
So thank you guys for having me today for the IAMA to host medical students here. Today I'm going to be talking about something a little bit different. This is a basic science project that I did in a previous life on the topic of cancer cachexia. This is a story that led to the discovery of the first causative biomarker for this disease. As a basic scientist in medicine, your job is to take a very obvious phenotype with no explanation and fill in the gaps. And there's no more obvious phenotype than cancer cachexia, to the extent that the clinical definition of this disease hasn't changed for over 3,000 years. And so I've given you 2 examples here. My Sanskrit is horrible, so you guys can read that yourselves. But suffice it to say that the definition of wasting in cancer really comes down to one thing, which is weight loss. And right now the definition is 5% within 6 months, with components of adipose wasting, muscle wasting, and anorexia. 30 to 50% of all cancer patients will experience this disease, and it independently drives 1/3 of all cancer deaths. The people that ultimately suffer are the patients, and despite this very long understanding of this phenotype of this disease, there are no FDA-approved biomarkers or drugs, despite 140 clinical trials documented in clinicaltrials.gov. And so to belabor this point that many oncologists, when they treat cancer, the cachexia goes away. But what you can see here is that compared to stage-matched peers, those patients who presented with weight loss at the time of diagnosis experience a 2-year decrease in lifespan. And so my goal, our goal in the group that I studied, is to try to close this gap. And our approach is to model a disease in a biological system. So this is an example of a cancer cachexia mouse model, where we can take a cultured cell line, inject it into mice, and observe over a 30-day period fat mass loss, body weight loss, fat mass loss, and lean mass loss. During the COVID pandemic, I worked with a postdoc who injected 54 of these different cancer cell lines of human non-small cell lung cancer lines into these special type of mice that can accept a human graft. And they essentially, we observed there were 10 lines that had incredible fat mass loss and lean mass loss. Sorry, one second, this is gonna be a little easier. And so what you can see here is that we have 10 lines that had that we call cachectic, and about 7 lines that that we use as controls. And what we want you to observe here is that they meet this models the clinical definition of cachexia. They have body weight loss, they have fat mass loss, and they have lean mass loss. My role was to explore gene expression changes or mutation changes in these lines. And so we used next generation sequencing to perform exome variant analysis of these lines. And so what I want you to understand here, is that these lines have mutations that are enriched in cachexia. These lines have mutations that are enriched in non-cachectic cancers. Some of the genes in here in the middle were things that were common to cancer. So P53 ended up here, KRAS was over here, but all the way to the right with the p-value that is frankly too small to count was this gene called STK11, which I had never heard about before. But some of you longstanding physicians might recognize this as LKB1, which is the gene associated with aggressive KRAS-associated lung cancers. It has roles in energy sensing, which suggests that it'd be relevant to cachexia. But what was very interesting is that it also, the loss of STK11 makes cancers more aggressive in proportion to secreted cytokines. And so really, this has actually now been published in JCI Insight, but what we were able to demonstrate is that when you take a cancer, GI colorectal cancer, that was non-cachectic to begin with, if you knock out this single gene, this cancer now causes mice to lose weight, causes them to lose lean mass, and causes them to lose fat mass. And so we were able to take data from liquid biopsies of cancer patients and find out that these variants actually do exist in non-small cell lung cancer cachexia. Those patients with weight loss do have a statistically odd ratio of 17 more chance of having a STK11 mutation, and that those patients with cancer and an STK11 variant do experience a decreased survival. And the big so what of this is that we can possibly target downstream factors, in this case IL-6 family cytokines that are elevated when STK11 levels, STK11 cancers, variant cancers are detected early on. This mouse model demonstrates, I'm just going to skip to this slide, that when you block IL-6 cytokines with a JAK inhibitor, we can see that these mice live, this is in mice years, about 2 years longer. Without actually affecting the tumor. So in a cancer-independent way, in a cachexia selective way, we believe that this might actually have a benefit to patients. And so my mentors were able to start a phase 1 trial that will result in 2025 with a small group of non-small cell lung cancer patients. And so I'm actually going to skip this model and just say that basic science moves slow, but with a really good team, it can move quickly. When I started in this lab, there was nothing, and in 4 or 5 years, we had my mentors put together a phase 1 trial and a biomarker for a disease that had none. So I just want to quickly thank my mentor, Rodney Infante, Beneath Iyengar at UT Southwestern, now Beneath is at Memorial Sloan Kettering, and our sponsors here. I also want to thank Windsor University of Medicine for giving me a new home in Chicago. And if there's any time left, I'll take questions. Yes. Right. So the idea is that somebody presents to clinic, they have cancer, they may not have frank weight loss yet, but you've detected the cancer, maybe you've done your job as a GI doctor, you've gotten their colorectal screening, you've caught these polyps early, but they don't have that weight loss yet. They haven't said, hey doc, this diet's working. It's not the diet, you know something bad's happening. But if they haven't had that weight loss, but you take their cancer and you detect this variant, then you know that this person's about to have a really bad time. And the idea is that we can now give them this. This is this trial. Remember, and I'm sorry, this is really quick. This treatment this isn't a cancer treatment. This isn't a chemotherapy. These tumors aren't shrinking. The cachexia was getting better, and that's why these mice lived longer. Which I skipped this slide. I should not have. So, thank you. Yes. Let me go back here. So STK11 phosphorylates and inhibits this molecule called AMPK. This is one of the targets of metformin. It's not the target of metformin in weight loss, but we think it's the target of metformin. No one knows the target of metformin in gluconeogenesis, but we think it's AMPK. And so the other end of this metabolic spectrum. So when we started this project, Ozempic didn't exist. We were really hoping we were going to find the molecule that could cause weight loss, but hey, Dan Drucker beat everybody. So, but yeah, if you reverse this, in theory, people should gain weight.
Thank you, Akash. Yeah, thank you. All right, so believe we are going to have our final presentation now. I'd like to invite Sejal Kodwani to come present her research. She's an M4 at Windsor University School of Medicine.
Hello everyone, my name is Sejal Kodwani and I have a keen interest in family medicine. So the topic of my presentation today is patient panel size in primary healthcare. So as we all know that primary health providers play a crucial role in healthcare overall, as they are the first point of contact for any patient. So we do have to make sure that we do have a proper quality, providing proper quality to all, treatment quality to all the patients. And for that, the major role comes in deciding the perfect patient panel size. So for today's presentation, I will be discussing on what do we mean by patient panel size and what is an ideal patient panel size in primary healthcare, and also the factors which plays a major role in when we decide for the ideal. The standard patient panel size is 2,500, which is absolutely not possible in primary healthcare. And according to this, if we consider this standard patient panel size, a primary care provider would be working 21.7 hours per day to provide quality care to each patient. So when we talk about the ideal patient panel size, we do mean that all the factors should be considered, all the variables which comes on the patient's and physician side both. So in the future slides, I will be talking about these factors. And also the good practice model. There are various practice models which use special calculations in which we can decide over a patient panel size. And also the physician resources. So what do I mean by physician resources is, for example, if a provider is seeing the patients, taking all the vitals, performing all the documentations and medical reconciliation by himself, would obviously see far more lesser patients than a physician who would have 2 MAs, PAs, and nurse practitioners. So this is where the physician resources play a major role. And there is a traditional equation which has been used for many years, which is supply equals demand equation. So this equation doesn't hold in account for all the factors, which we will talk about in future slides. So this equation has a lot of limitations. So that is what I will be addressing today. So when we talk about these factors, so these factors are the patient factors, which are patient demographics, socioeconomic status, health conditions, and also the disease burden. So for example, if a patient the patient age is less 0 to 11 years, would have more patient visit as compared to a patient who is in his 30s. So this is where age plays a major role, and also the health conditions. If a patient is having a lot of health conditions like diabetes and hypertension, that particular patient will be needing more visits as compared to a healthy patient. And also the physician individual needs, the physician resources, as I was talking about, the teamwork, which includes MAs, PAs, and nurse practitioners. So I will be also discussing a study which has been done, which has a model which will give us a highlight on how this can be addressed as well. So when we come in calculating the patient panel size, the first thing is patient empanelment. By patient empanelment, we have different models which are laid down. And one is the look back period, which is by the American Board of Family Medicine. In this study, we usually go back, and if a patient has not been seen for more than 3 years and not been documented for more than 3 years, would be excluded from the physician panel count. And this is the forecast method in which we just access the patient visits and we see the majority of the visit by a particular physician and address it to that particular provider. So calculating optimal panel size, there are various worksheets provided by the American Board of Family Medicine, which also includes the factors, physician factors, for example, the full-time equivalent providers, and it gives an idea of the current panel as well as an ideal panel. And this is the way which we can use different scores and to access the risk management of a particular patient, and this can be implemented in EHR built-in risk adjustment model, which would give a clear idea of all these factors. And this is what I was talking about, the study in which different providers like MAs, PAs would play a major role in dividing. So we can see that in a non-delegated model, we see that the patient panel size is quite reduced, as well as it can rise to 1,947 patient panel count, in which there is some involvement of PAs, MAs, and nurse practitioners. And these are all the references which I used for this, to explain these study modules. So I hope this 5 to 7 minute presentation has made an impact of how we decide the patient panel count and how it plays a major role in primary health care. Thank you. Any questions? Yeah. Thank you. Thank you. I think that this is a major topic to discuss on. I was already working on this, and I thought that since there would be quite a lot of providers, and I should address this topic here because it has to be taken care of. Yeah. Thank you.
All right, thank you, Sejal. So, at this time, what I'd like to do is take a few minutes to introduce our judges. So let me start by introducing, this is very loud for me, because I gotta do that. Okay, how's that? I think that's a little better. Yeah, I don't need it so loud. Thank you. Yeah, that's better. Yeah, that's fine. Thank you so much. So first I'd like to introduce Dr. Vemuri Murthy. Thank you for being with us today and serving as a judge. He is an adjunct associate professor in the Department of Emergency Medicine at the University of Illinois College of Medicine in Chicago. He's also a visiting professor to Indian medical universities like AIMS, the All India Institute of Medical Sciences, and of course we all know his passion and his deep dedication to heart health. And so in that regard, he's involved in a number of Indo-US cardiac arrest research projects, and this has been the case for many years. And I also just want to say that he's one of my most important mentors, and I thank him for that. Next, I'd like to introduce Dr. Kalyani Perumal. Thank you so much for being here with us today. Dr. Kalyani Perumal is currently serving as the chairman of the Division of Nephrology at Cook County Hospital. She's a board-certified internist and nephrologist and has been working as such for over 20 years. Dr. Perumal finished her residency at Cook County Hospital, and then she completed a fellowship at the University of Illinois at Chicago. In addition, she holds a master's degree in clinical and translational research from the University of Illinois at Chicago, and I heard those questions about translational medicine. So I know, so she's going to be your go-to for your future work if you have questions around that. And of course, she has published many publications in the field of nephrology. Lastly, I'd like to introduce Dr. Lalita Darpa. Thank you so much for being here with us today. Dr. Darpa serves on the board of Oak Technology Solutions. She also serves on the board of the IAMA Charitable Foundation and Indian Trail Town Home Association. She is board certified in internal medicine. She's a fellow of the American College of Physicians and has been so since 2011. She serves on the Advocacy and Policy Committee of the Illinois Association of Free and Charitable Clinics and Education and Health Workforce Committee with Illinois State Medical Society. She's a clinical lead with the prestigious ACP's Doctor's Dilemma competition at the national level, and her recent work includes meeting the Illinois State Governor and Magic Johnson. Love it. So with that, I would love for the judges to come here and just please, so that we can just thank you all as a group. If you could all, Dr. Vemuri Murthy, Dr. Kalyani Perumal, Dr. Lalita Darpa, please come.